Today, my group and I will be talking about the musculoskeletal pathology of plantar fasciitis and how an elevated BMI, among other risk factors, can impact on the development of this pathology. This will help us in screening for risk factors and put in place an injury prevention program in an attempt to prevent the development of plantar fasciitis among the athletes.
First, we will look at the pathological process and epidemiology of plantar fasciitis. Plantar fasciitis is a locally inflamed condition of the plantar aponeurosis of the foot known as the common cause of inferior heel pain. The pathological process involves excessive loading of plantar fascia caused by foot pressure, elevated BMI, footwear, and biomechanical factors that alter internal pressure at the plantar fascia, which causes micro tears leading to inflammation and thickening. Epidemiology. About 2 million Americans are affected annually, and 10% of the population is affected during the course of a lifetime. 5% of those diagnosed by plantar fasciitis undergo surgical treatment. It is common in people with sedentary lifestyle, military personnel, and athletes. It is common in aged population of about 40 to 70 years due to weakened medial longitudinal arc, which is supported by the plantar aponeurosis. Women are more prone to having plantar fasciitis than men, as seen by the research done by Ozdemir and his colleagues, which shows the ratio of men to women with plantar fasciitis is 1 to 2. Now we will look at the theoretical mechanism in relation to elevated BMI. Increased BMI and age has important role in development of pes planus foot posture, which is then theorized to be decreasing calcaneal pitch and increasing stress on the plantar fascia, causing extreme stress and pull on the origin of the short flexor muscle. This causes inflammation and formation of secondary proliferation that forms the calcaneal spur, which eventually causes heel pain.
Before beginning our research, it is vital that a structure is formed using PICO, a useful tool for asking focused clinical questions. Starting with P for population, our chosen population are the elite athletes from the leading sports club mentioned in the case study we are conducting the study on. Our intervention for I is the elevated body mass index, as we believe the patient's weight has the main bearing on the clinical study. Our comparison for C would be the average range body mass index, as we're comparing whether there will be an increase in pain from a healthy body mass index to an elevated body mass index. For O, the outcome we are expecting is an increase in pain at the plantar heel and plantar fasciitis. As such, the PICO question is as follows. In elite athletes, does an elevated body mass index compared to a healthy body mass index play a part in leading to an increase in pain for plantar heel and plantar fasciitis?
The proposed risk factors of plantar fasciitis are the limited range of ankle motion, particularly the limited or reduced or restricted ankle joint dorsiflexion. When an individual presents to the podiatry clinic on objective examination, if we notice their ankle joint dorsiflexion is less than 10 degrees, this makes them prone to developing plantar fasciitis or heel pain. The second most common reason is increased body mass index. If an individual weighs or if an individual's body mass index is more than 25, that puts a lot of pressure or stress or a lot of forces on a particular area on the plantar fascia, and that makes them prone to developing plantar fasciitis. Also, prolonged standing at work during the 8-hour or 10-hour shift, such as security guards during Melbourne Cup event, or high intensity exercises such as elite athlete runners who train hard, who compete over and over again. Those sort of jobs or professions make them prone of extra stresses or pressures on their fascia, on the plantar fascia, and that causes or develops plantar fasciitis down the track. The age and body weight have a positive relationship, as shown by the studies done by Prishasuk and Supradha Bandhu in 1994. Generally, when the age increases, the body weight increases in most, not all the cases, and this may lead to the development of pes planus foot type, and which basically develops or causes the chances of developing plantar fasciitis.
Identifying levels of evidence using the NHMRC evidence hierarchy. The study carried out by Ozdemir et al. 2005 is a case control study. Therefore, at etiological level 3.3 on the NHMRC evidence hierarchy. Using ultrasound, plantar fascia thickness was compared between 39 patients with plantar fasciitis and 22 control patients without plantar fasciitis to determine the relationship between the incidence of plantar fasciitis and its thickness. The study carried out by Prishasuk and Subhandrabandhu 1994 is a prospective cohort study. Therefore, at etiological level 2 on the NHMRC evidence hierarchy, 82 patients with plantar heel pain and 400 control patients without plantar heel pain were followed prospectively over 3 years to study the relationship between pes planus foot type and calcaneal heel spur in patients with plantar heel pain. The study carried out by Riddle, Pulisic, Pidco and Johnson 2003 is a case control study. Therefore, at etiological level 3.3 on the NHMRC evidence hierarchy, 50 patients with diagnosed plantar fasciitis were matched with 2 control patients each to examine the relationship between plantar fasciitis and some of its risk factors, including limited ankle dorsiflexion with the knee extended, obesity, and time spent weight bearing.
I'll now talk about the results from each of the studies and their statistical significance in relation to our proposed risk factor in causing plantar fasciitis. The article named Risk Factors of Plantar Fasciitis by Riddle displays results that suggest that people with a higher BMI have a higher chance of developing plantar fasciitis, as the odds ratio in groups with the odds ratio is higher in groups with a higher BMI. Displaying confidence intervals that do not drop below the value of 1, as well as a p-value of 0.01, means that the results are statistically significant and that less than 1% of the results occur due to chance. The second study, conducted by Ozdemir, also displayed statistically significant results showing a positive correlation between BMI and plantar fascia thickness, as R equals 0.387 and the p-value being 0.04, meaning that 4% or less of the results had occurred due to chance. The final article by Prishasuk displayed the relationship between BMI and calcaneal pitch. With a p-value of 0.05, the result suggests that a higher BMI decreases calcaneal pitch. The study also shows that the BMI range of the group with heel pain and without heel pain. As we can see, with a high t-value of 8.09, there is quite a large difference between these two population groups, as well as a p-value of 0.001. The results are statistically significant.
Recommendation is classified into grading system: strong, moderate, and limited. Strong classification is reserved for the highest hierarchy of research designs such as RCT. Based on the articles given, article by Perchasak and Subhandru Badu 1994 is classified under moderate class grade. Perchasak and Subhandru Badu is a cohort study. Traditionally, this type of study is more time-consuming, costly to conduct than case control studies. This research had 400 control patients, which is consistent with the cohort studies, which generally have a large group often consists of hundreds of subjects without symptoms. Subjects within cohort studies are followed for extended period of time. This is evident in this research, which followed participants for 3 years. The research outcome is supported by other studies as well. The article highlights several references to the relationship between the plantar heel pain, tooth spur, and increased BMI. Article by Osmer et al. 2005 and Riddle 2003 are classified as limited categories or grading. Osmer et al. 2005 is a case control study. The findings are statistically significant. However, the research suggests that the finding might be used as an objective parameter in the diagnosis of plantar fasciitis. The research also highlights that the relationship between plantar fasciitis and high BMI has not well established. There is need for further studies to explore the relationship between plantar fasciitis and high BMI. Riddle 2003 is also a case control study. For this reason, as with Osmer et al. 2005, the study primary limitation is the temporal relationship between BMI and plantar fasciitis cannot be examined because cases are assessed only after the disorder has been diagnosed. This study has a small sample size, and the article stated that not be generalized to athletic population. There is a lack of evidence in the literature for cost efficacy. A case control design was used. The study also emphasized the need for strong evidence through a cohort study.